Little button, and everybody's green. Good afternoon again, ladies and gentlemen. It is Tales from the Heart, second edition for April 19th, 2024. Earlier today, you heard from Dr. Lubna Chowdhury at Northwestern. And today, in this segment, I am joined by Dr. Matthew Martinez and Dr. Anjali Owens, Morristown and UPenn. We got the East Coast representing here today. And this is a special edition of Tales from the Heart, as it is approaching within a few days now the second anniversary of the first labeled indication medication for the treatment of obstructive hypertrophic cardiomyopathy. We called it mavacamten during the clinical trials, and 2 years ago we started using the word Camzyos. So typically, HCMA does not endorse a particular brand name drug, but it is the only myosin inhibitor on the market today. So we think it deserves a little special attention. And we wanted to do a deeper dive with you to discuss where are we 2 years in to using a brand new class of medication in a disease that's as complicated as hypertrophic cardiomyopathy. So that's my run into what we're going to be doing over the next few minutes here with our panel. So I'm going to start because Matt got here first. So I'm going to go Matt first, then Anjali, even though he only beat you by a minute or two. So Matt, you have been prescribing Camzyos for almost the full 2 years that it's been available. What has been your overall experience? Then we'll jump into some numbers and some availability.
Yeah. So the experience with this overall has been quite good. I think we've been happy with the response from patients and the benefit to the patients in terms of symptoms. But it hasn't been an unbumpy road. There has certainly been bumps where the approval process has been challenging. The ability to get the drug in their hand can take longer than I would like it to. There's a bunch of complexities with that in terms of not only just getting the prior auths and approval, but it gets directly shipped to their house. Are they available? Are they on vacation? That process is cumbersome. And then the echo process is equally cumbersome, where if they're away, can I get an echo somewhere else? How do I review the echo? How do I get the echo sent to me? And then the third part that's confusing to a lot of patients is they're just not used to getting a fixed number of pills. And even once they get to the maintenance phase of the 3-month phase, they're still getting a month at a time. So that means they have to be somewhere to get the drug. And I know that all those things are being addressed, and we've learned quite a bit. I think most of that will change in the next few months. But from a patient perspective, it has been a significant win in terms of symptoms and improvement for folks who, A, were not good surgical candidates, B, couldn't afford to do anything else. They were too scared to go to surgery, or they just were not good candidates. Alcohol ablation wasn't an option for them, and they were miserable despite high doses of AV nodal blocking agents. This has been a real game changer for those folks. And there are certainly challenges. The atrial fibrillation message is still ongoing for me. I'm still trying to sort out what to do with atrial fib. In my experience, the real challenge becomes when it's mavacamten and they develop atrial fib and how that interacts. We really need to be aggressive about that. But otherwise, I'll be honest, it's been good.
Honesty is good. So, Anjali, I think you have one of the largest Camzyos clinics in the country right now, which then means the world. So, give us a perspective from the Penn point of view. What's going on?
Definitely, and I echo a lot of what Matt just said. So we are following a large number of patients now on MAVA. I will always still call it MAVA from the clinical trial days. And for the most part, patients are doing very well, and they're excited to have a new option. They are compliant for the most part and looking forward to starting a new medication and doing what it takes to stay on the medication, which does require commitment in terms of the follow-up visits, the follow-up echoes, being able to arrange their medications, as Matt was saying. I think the biggest hurdle is logistics, just exactly what we heard from Matt. This is a new process and a new way of titrating a medication for many of us in cardiology. And so it requires operations and logistics, and that is not often our, our strength as cardiologists. And so we've had to learn how to do this. And I think, like anything that's new, you've got to figure out what works, what doesn't work. You've got to troubleshoot. You've got to be a little nimble on your feet. The Friday afternoon calls come in, and you got to troubleshoot. And I think that's what we've seen for the most part. You've got to be aware of drug-drug interactions, for example. So there's a lot more communication that's coming from our patients. We've told them, be wary of intercurrent illness and AFib, and let us know if these things occur. So there's a lot more involvement, and this is a team effort. Yeah. And I think that's what it's really come up in our center, is that the way that we're able to manage this large number of patients is by having a real team, including our nurses, our nurse practitioners, of course, the physicians, the specialty pharmacists. All of those people go into making this a success. And so it's not a drug that you prescribe and walk out the door and say, I'll see you in a year or 6 months, right? This is an actively managed medication. But when that's done, patients love it. They feel great. They're doing things they haven't done in years. And that makes it worth it for the team, because we see that, and I think that gives us the motivation to say we can do whatever it takes, because the patients are really doing well.
Yeah, I love what you said about the team. It could not be overstated how important it is. And I'm sure in your clinic, like ours, we have over 100 as well. And the process that I put in place when we first started doesn't look anything like the process now. And the nurses are doing all the work on this. They are changing it and coming up with better processes. So they are absolutely to be thanked for this. They are huge.
And in many ways, they're much better than us at doing this. And so they are very much able to not only follow the algorithm, but then troubleshoot in a way that makes it helpful for patients. And so I think that's what we've seen in the last couple of years.
So according to information that I have received from the folks over at BMS, as of February 24, so these are publicly available numbers. This is all, reportable through like SEC and all that fun stuff. There have been more than 8,000 prescriptions written. That doesn't mean that 8,000 people actually followed through on that prescription, but it's probably very close to that. And that means the trials, which we did, the drug was approved upon, were less than 300 patients. And now we have 8,000 or thereabouts real world utilization outside of the clinical trial. Some of these patients are being followed up in trials. Some of them are not in trials, so just out in the community. What are we seeing in terms of signaling from these larger populations? Matt, you just gave some data at ACC on the REMS program. So what's happening in the real world out there with patients?
Well, I think what we just reflected on, I think is what's really happening. And I think that in general, they're very happy with it, but they are frustrated with although tolerating it, seem to, sort of doing all that without a complaint. I think they're asking, I don't understand. The last 3 echoes have all been the same. Why am I need an echo again? And so I think it's on all of us to gather the data, because it's all about safety and it's all about making sure the patients are safe. And I think that they recognize that. And what we showed at ACC, I think, reflects some of the discussion we just talked about it. And it was only the first 10 months, so I don't have the full 2 years worth of data, but obviously that's the data that was available at the time, because they do like these cut time points, and this was the available. So the first year was really 10 months. And it was over 1,500 unique patients that were on the drug, 1,866 active patients, but we only had full reports on 1,524. And there were 2 important messages from that. And I think the first is that 2.8% had, or 43 total of that total number, had a decreased ejection fraction under 50%. So that tells a different story to all of us about what that looks like. And we can't dive into each of them individually, but anecdotally, you heard from Anjali, and I would agree completely. We tell them about concomitant illness. If you get a UTI, if you get a pneumonia, if you change a medicine, that's usually when that happens. So it's usually MAVA and something else happens to you. You develop an infection, you develop atrial fib, and then that's ended up being that decrease. We don't know how many of them were held the drug, treated, and then came back on the drug. We don't know that. The REM system doesn't allow that. The other important message was that the drug-drug interactions, which a lot of us really feared, turned out to be less of an issue than we thought. So none of the patients in that group were, there were like about 23 that were identified as a contraindicated medication, and about 100 or so that were identified as a relatively important drug to reduce the dose of mavacamten on. And none of them required a drug stoppage of mavacamten. And of that small percentage, all of them ended up getting an adjustment of the other medication. And that goes back to the team, because most of that, for me, is happening behind the scenes with the nurses and the pharmacists, who are all reworking those medicines and saying, you're on this type of a proton pump inhibitor, we need to change you to a different type of proton pump inhibitor. So I think the message was that it's still important to manage folks, to look for surveillance by echo, to look for LV dysfunction, because we're definitely seeing it. Some people are very early responders and they go down sooner. And then after a couple of months, at least in my experience, after 8 to 12 weeks or so, once they're on a stable dose, if they don't get another infection, they don't develop atrial fibrillation, nothing seems to happen. We need more data to try and support that. And then the drug-drug interaction conversation, although important and still requires a team, hasn't been as big a barrier as we thought. So I think that was the take-home messages.
So in my previous conversation today with Lubna over at Northwestern, she mentioned that flu and COVID and medicines that you might be taking might need to be stopped or paused for a couple of days while you're facing another challenge, we'll call it. So whether it's an infection or a virus, what are you guys doing about real world stuff that happens out there? We get the flu, we get COVID, we get sick. How does Camzyos impact that, Anjali?
Well, definitely Paxlovid is contraindicated with mavacamten. So we do have to stop the MAVA if you need to go on Paxlovid. So that's an important one. To just go back to what Matt said, I wonder in that data, Matt, where they, at what point they sampled the drugs that the patients were on, because some of the early adopters, as you know, were large centers like ours, where you were screening that patient before you're going to write the prescription. And I think many of us had already maybe switched the proton pump inhibitor over. So I was a little surprised that it was 23 or whatever it was patients. And I wondered if maybe some of those large centers had already switched people over. But I think, as time goes on, we'll get more and more data accumulated on what the change in medications are. But we haven't found anyone yet that it's been insurmountable. And I think that's important. This, again, will require active management. But it's not prohibitive. In most cases, patients with all kinds of comorbidities, we've been able to get them on therapy. And to your point, Lisa, in terms of how is this real world experience different and expanded from what we saw in the 250 patients and 112 patients in the clinical trials, now we're seeing patients with many more comorbidities who would have been excluded from those original, phase 3 trials. And we're getting to see how they respond to the medication. So it's a different mix of patients, more complex, both from a cardiac standpoint and from a non-cardiac standpoint, because we're including people that would have otherwise been excluded. And I think that's important. And it's important that we publish that real world data so that people know what to expect. And the most important thing is, what is that conversation that you're having with the patient? What can you tell them to expect in terms of potential benefit and potential side effects? And I think the more we can inform that doctor-patient conversation that eventually occurs on an individual basis, but informed by this data, is really what we need to offer and to bring to the table. for other people.
So I'm going to ask a tricky question. So we have a lot of people out there now taking the medication, and you guys are, kind of known for your knowledge of hypertrophic cardiomyopathy and all the other things that go along with HCM and the complexities. I'm seeing a slightly different prescriber out of the community, and we're starting to see these. Well, I'm my doctor's first patient, and I'm a little nervous, gotta be honest, because some of these people, I'm looking at their documents, and I'm going, I don't know that another center would start you here. They would maybe start you someplace else. So, do you guys have any words of caution for community cardiologists trying to prescribe and having a newly diagnosed person at a community center, community cardiologist, starting their HCM medical management with a myosin inhibitor? Any words of caution for these folks?
Well, I guess what I'll say is that this, Anjali said it earlier, this is a team sport. And it's a team sport in your own institution. And I would argue it's a team sport in your own community. And at least Anjali and I sit sort of in a tri-state. And that tri-state, I'm close to New York, we're in Jersey, close to PA, close to Connecticut. I mean, there's a lot of intermingling. And the way I view this is that they're not my patient, they're ours. And that I still think that there's a real benefit to being sent in for a comprehensive assessment from somebody who says, we do ablation, we do surgery, we do a lot of Camzyos, we do disopyramide, and having that smorgasbord of a discussion. And at least what I've learned over the last 2 years is that I was pretty sure you could predict who would do what, and I was completely wrong. The patients tell you stuff that I am like, well, that's really a thoughtful, you're right, we should not do this. So what is that? It's a patient that you thought maybe was a higher surgical risk and says, I don't want to do this, I want the surgery instead. Or they're a young woman who says, I still think I'm going to have babies and I don't want to have to worry about being on this medicine yet, I'll take the surgery. And others who you say, you're a really good surgical candidate and you would be a great opportunity to do this. And you can see the sweat beads coming on their forehead. And they say, yeah, I want to try the drug first. I want to see if I feel a lot better. And then I'll talk to you about surgery. So what I would say to patients and to community cardiologists is that we're all in this for the same reason and that we can do this together. So what I love doing is getting them in, starting the medicine, and making sure that they're titrated those first couple of echoes, and then saying to the community cardiologist, all right, you're in, nice and stable, call me if something changes, this is the dose they're on, you guys continue to do the echo, or you do the echo and I'll see the patient from a telehealth perspective. So I still think we're in this together. And the other part that I don't want to get lost in this, and I've had to remind my own team about this, is that it's not only mavacamten that we're managing these patients with, that every year we have to talk to them about other stuff, right? About pregnancy, about genetic testing and screening their family members. And sudden cardiac death risk stratification doesn't go away just because you're on mavacamten. And we just had patients develop severe aortic stenosis. So there's other things that have to happen. And I still think that's a collaboration. I know that's how Anjali does it, but I'm curious what she thinks.
Yeah, no, find a buddy, find a regional buddy, someone who you can call. Our phones ring all the time and people say, do you think this is a reasonable thing? Should I do this? Should I not? And when it's straightforward and we can answer over the phone, then that doesn't even require the patient to travel down. When there's a bit of an issue and you think it could be a gray zone area, then absolutely it's worth that trip at least once to get an overview of kind of here is the 6-month year plan, and then go ahead and execute that plan as a team. And having that buddy is critically important, because if something comes up and you just don't know what to do, it's always good to have a buddy. And I call Matt all the time. He calls me, and we are supposed to be experts and we still need buddies. So I think it's a great opportunity to just really share care and share knowledge of these patients. And it's better for everyone.
I think you brought up a couple of really good points, and I didn't even have to seed these ones. You guys live it every day, and we live it from a different perspective. Community cardiologists want to be involved in care, but this is complex stuff, and if they only see a handful, go to an expert, hub and spoke it. You'll get the patient back eventually, and it'll be a team. And the community cardiologist will learn from the experience. The patient will learn from the experience, and the clinician learns. You guys learn from the experience. Okay, what are their questions? Where did they not quite understand? How can we help explain this? So as we're learning how to bring a new class of medication into our world, we're teaching and doing simultaneously, which patients aren't always the most comfortable with. They just want you to know everything all the time without question, but we're learning together.
Yeah.
And I think we all have to be aware that we're still learning together. And it's going to keep going because additional classes of myosin inhibitors, different variations are going to come to the surface at some point, and we're going to have to figure out how those ones work too. So,
well, and I'll just add one other part to that they're not going to come to our institution for everything. They're going to break a leg. They're going to have a gallbladder that needs to be managed, or a cataract surgery, things that they need to have a local cardiologist who is comfortable saying, yep, we're fine, carry on. Or that can, as Anjali says, reach out to a buddy, right? They'll text me and say, just want to make sure, right? They came in with this, we're still in a good place, right? Or I had one that just said to me, the ejection fraction's dropping. It's like 51, 53%. Should I be worried? And I said, well, are they still in rhythm? No, they went into atrial fib like 3 weeks ago. Ah, perfect. Now we got to get you out of atrial fib, and that back and forth. They can't see us for everything. Not only do we not have the bandwidth, but they can't be coming to you for acute scenarios where we need them to stay on the drug or to come off the drug, and that conversation has to happen with a local person.
So we know now that Camzyos is approved has regulatory approval on 5 continents: Argentina, Australia, Brazil, Canada, Great Britain, Hong Kong, Israel, Singapore, South Korea, and Switzerland, in no particular order. So it's not just a US thing anymore, it's turning into an international thing. And how the drug is being rolled out in each country is a little bit different. The pricing is a little bit different. Of course, Americans pay more because that's the system that we've set up. We can go into an entire podcast on the healthcare system and pricing, but we'll hold that for another day because it's not specific to this particular agent. But availability is increasing. Visibility is increasing. How many Camzyos commercials have you seen in the last 48 hours? I can count 6.
Wow.
I think I'm their demographic. CBS morning TV in New York area, I always get to in the morning. So if I'm watching, so that's 2 yesterday morning and 2 this morning. I don't spend your money someplace else. I got the message already, even though I do like watching John take his hikes. So we're seeing a lot more. You guys seeing it? You're hearing it?
Our patients surely are, because they are, bringing it up and saying, oh, I'm seeing a commercial. And a few of our patients that were in Explorer Valor, like, am I the pioneer that they say in the small print at the bottom with the 250, So they're definitely seeing it, which is great. I think it's, it's par for the course. With regard to the global rollout, though, I think it's going to be fascinating, and again will give us a lot of interesting data. As you know, some of the countries in Europe are requiring CYP genotyping so that we know metabolizer status to inform dosing, and I think that's an interesting strategy and one that might give us, again, useful information that we can use for the rest of the world. And I'm fascinated to see that. We know that in many other countries, it's not sonographers doing echoes, it's the cardiologist at the bedside, maybe with a handheld device. So I think it offers a lot of opportunity to see how we can optimize implementation and, just clinic operations, how we're treating these patients. I think we can learn a lot from what the world is doing and maybe come up with better patient care flows in the US.
So I'll bring a unique perspective to the table. So yes, we're the HCMA, but I'm also an employer, right? And one of my staff members has to take an awful lot of time off to go get her damn echo done. And It's like you look at it on the calendar. I got to go for my Camzyos echo. I'm like, oh, can't they do this on evenings and weekends? And no, because the sonographers aren't working then. So I do think we need to find ways that you can embed the management of your disease into your life without disrupting work, family, etc. I think we all are a little frustrated with parts of the REMS program. However, I still stand by the fact that I think it was the right decision for the FDA, given the amount of data and given the amount of time we had out there. Now we have real world experience. And I would hope that with real data, we can go back to the regulatory bodies and say, here's what we're seeing. Is there a way we can alter this? And I think that will come in time. What do you guys think?
Yeah, I sure hope so. I think it will. It's on us as academics in this community to really dig down, though, I think, and understand how to be more sophisticated about risk stratification for who is at risk to drop their ejection fraction. And, many of us who've seen a lot of patients now suspect that it's this group that may have some risk markers. And can we look into that and really understand them? And that this group is probably fine. And then we could concentrate our safety efforts, monitoring on that smaller group that's really potentially more at risk. And we do that with every other condition. Why aren't we doing that here? And so I think in the next couple of years, we really should look into that so that we understand it better. And perhaps we would even go to ways of echo that are remote echo or some other, fancy patch that doesn't require an echo or something, so that we're not doing.
Okay, wait, you just dropped a concept here.
Yes.
So I'm going to make you explain that one a little bit, because people are like, patch echoes, I'll get one of those. So we all just came back from the American College of Cardiology, new data, new technology, new concepts being pushed, some trials, etc. So you want to give them an idea of what this patch echo concept might be?
Well, in theory, because again, I'm being a little sick on purpose, that there are a number of companies developing technology that you may even be able to correlate EF, gradients, perhaps, et cetera, concomitant valvular disease, and get an understanding of what's going on via a non-invasive patch that takes, a few minutes to have on. But we need to do the validation studies. We need to do it at the same time that we're doing these safety echoes, so that we understand in a cohort of patients what this looks like and know if these new technologies can give us that information without the echo. And potentially they can. And I would say that would be very powerful. If we could send, do the patch at home or in their local place and transmit the information, that could be really, really helpful in the long run.
Yeah, I also think it will help with diversity, right? We talk about opportunities, and not only is it cities that have challenges, right? I've had patients say to me, look, it's 2 bus stops for me to come to you. And those are moments where I'm like, boy, I hadn't even thought about the complexities of getting a ride. So, Lisa, you talked about time off. Now, not only is it time off, which is very real, number one. Number two is, how do I get there if I don't drive? And then what if I live 3 hours from the nearest opportunity? Can I do this at a local Walgreens? Can I do this in a barbershop? Like, is there an opportunity for me to show up, get a technology, and then have a telehealth visit with my doctor? I think it's on us to figure out ways to improve opportunities for patients to get the drug. Not can we, but should we? How do we figure out ways to get people more exposure to a drug that is life-altering?
Yeah, and it is about access. We've talked about it with SRT. It's going to be the same thing. We really need to be able to provide access to all of our patients, and not just the ones that live within 20 minutes of an HCM center.
Yeah.
I'm going to sneeze in a second. Now that I've said it, I won't. Okay. So let's dive into that. You set me up for this one as I was about to sneeze. I don't care if it's a bus ticket or a plane ticket. If you have financial need, the HCMA provides Lorry Fund opportunities. So all you need to do is apply. If you need an Uber ride across town every month for 6 months, that's certainly covered within the $600. You can submit an application and you can just submit the bills as they come in and we'll reimburse. We don't want you to go without food or medicine so that you can get your medicine if it's going to be that costly for you. So we've created that program in memory of my sister, and I'm happy to provide it. And if you need it, use it. But we do need to come up. Obviously, we're not going to be able to pay for everybody's plane, trains, and automobiles. We can do that when there's a real deep financial need. So we do need to find better technologies to manage complicated medications on top of complicated diseases. But I think we've proven that we can operationalize up really well in the HCM community. We've figured out ways to make this available. And from the patient's point of view, they may not be completely aware of all of the logistics and administrative gymnastics that have had to take part behind the scenes to make this look as seamless as it is. And there's still bumps in the road. So stick with your program, explain pain points. If you're having a problem with your insurance provider not providing coverage, we've been fighting a couple of fights. We had an issue with Priority Health in Michigan. They took it off of formulary. That never put us on formulary. So we went to the state house. We argued with the payer and said, this is why it's needed. Now they have put it on formulary. It does require a pre-auth, which most do. But how much time are we taking from our staff doing pre-auths for things that really should be kind of part of a contract? So HCMA is having conversations with different payer organizations. Let's try some different things. Let's see if we can do this a little bit better and stop wasting your staff's time and our staff's time doing minutia paperwork that you're going to say yes to because you have been.
Yeah.
So we're fighting those fights. And
100%. And it also goes back to the whole team approach, right? Because Anjali knows that the first, you do the first 3 or 4, it's hard. Once you get to 30 or 40, it gets a little bit easier. When you get above 100, it gets harder again. So,
really harder.
Really hard. And our nurses are great about this. And Medicare patients are harder. So they'll say it's no problem. We just have to have them fill out the paperwork. The company's great about this. They're able to create all these things. And the only reason we know about what Lisa does and what is offered is because we have done enough of them. And rather than after 40 minutes of this, the doctor is saying, I give up, you don't qualify. Our 2 nurses are doing the thing behind the scenes, right? It's all magic to me. And I think that goes back to that initial team discussion, right?
Yeah. And the easier it can get in the future, the better, so that those, team members can focus on other things. Just as you said, we don't want them needlessly doing paperwork and logistics and phone calls and waiting on hold when they could be talking to our patients and seeing patients in clinic. So, obviously we appreciate everything you do, Lisa, to try to get those things moving forward, and relieving the unnecessary burden of paperwork.
Well, that's why it takes a village, and we all handle our own perspectives of it. We helped recruit for clinical trials. Now the drug is available. Now we have to help people get the drug that we helped the clinical trial on. And it doesn't stop. It just changes. And the reason why it's worth it to me is moments like this one. Actually, Anjali, I think you had just left Switzerland last year, and I was in the audience of the World Heart Federation and listening to some talks from, I think it was the health minister from Jamaica or something. And I happened to look down at my phone and I get a bing, there's a message on Facebook. And it was from a woman who we've written about in in the new magazine, Maya's experience with HCM, with Camzyos, with mavacamten. And she said, I was able to go to the grocery store and walk the grocery store for the first time in like 2 years. My husband was shocked. And it sounds so simple to be able to go grocery shopping. But for so many people with HCM, these are things that they've avoided doing because it just took too much energy and they got too short of breath, and they learned to live without it. So after you can't do something for a while and you do something as mundane as go to the food store and you buy your groceries, and you go, holy crap, I was able to do that and breathe. it's not a really high bar that we're trying to get over here, people. We just want to go grocery shopping. And to see her be able to do that was just, okay, this is good. We're helping. And she didn't have to have open heart surgery to go food shopping. And that's great too. But we're not to the finish line yet. We don't have enough data to say what this is going to do for the non-obstructed population. The apicals have kind of been left out of a lot of this trial work, so we need to learn more about how it impacts them. We do have a question from the audience I'll pop in with real quick. Does the presence of a PFO impact a decision regarding a myosin inhibitor?
No.
I didn't think so, but I'd let the doctors answer that one.
No, and especially, PFOs are super common. So whoever's asking, these are often incidental findings that have no impact, and they have impact in some scenarios, but in the majority of folks, we find them and then we move on. So I would not have any reservation if you have a PFO with starting a CMI. I'm
going to put an announcement out now that if you have any questions related to myosin inhibitors and hypertrophic cardiomyopathy, or if you're a patient who has had an experience that you would like to share, please drop it in the stream right now, whether you're on Facebook, LinkedIn, YouTube, or X. We'll see it here on StreamYard, and we'll be able to comment on it or share your experience. So don't be shy, because I know a few of you are out there who are on this right now, and you're really happy. And I also know that there's some people out there that are a little concerned because of atrial fibrillation. And it has been a confounding factor in trying to figure out the place for myosin inhibitor in somebody who's already had AFib. Who wants to talk about AFib? Let's talk about it, that AFib is present when they're considering a myosin inhibitor. What do you think clinically at that point?
Well, I'm happy to start and then let Matt add in, but we generally speaking try to keep people in sinus rhythm. And in particular, if we're going to be starting a myosin inhibitor, we prefer for the patient to be in sinus rhythm. So we generally try to do that first and make sure they're stable on whatever medications they need, if it's an antiarrhythmic or if they've had an ablation or they're going to have an ablation or cardioversion, and stabilize that rhythm first prior to starting the myosin inhibitor. And then we're very strict with our patients that if they go back into AFib, we want to know about it, not 4 weeks later, but when it occurs, so that we can get on it and manage it the way it needs to. We know that, patients with HCM and AFib, even without a cardiac myosin inhibitor, are at risk to drop their ejection fraction and to feel terrible and to go into heart failure, and we don't want that. So we know that with a cardiac myosin inhibitor, certainly that can occur. And the effects may or may not be exaggerated. I think, as Matt said, jury's out on the mix between, myosin inhibitors and AFib, and we need more data to know how to manage this. But our approach here is to try to keep you in sinus rhythm if at all possible.
Is there any problem in using some of the other pharmacologic agents for AFib management, starting with sotalol or even going a little bit more hardcore like Ticasin? Can these drugs be used in combination?
Yes, they can. And we use both sotalol and dofetilide in our patients with AFib who are on mavacamten. There is a drug-drug interaction with amiodarone, which of course we try to shy away from unless we have to because of the other side effects of amiodarone and longer-term effects. So we usually put that lower on our list and use either dofetilide or sotalol if needed. Of course, sotalol has beta blockade effects, so if they're already on a beta blocker, I think be cautious of that. But we do use both agents. And Matt, I'd be curious to know your approach as well.
Yeah, I do the exact same way. Everything you said, I wholeheartedly agree. Exactly the same. We've used sotalol with it. I still think more data needs to come. If we say that atrial fibrillation is occurring in 20 or 25% of patients with HCM, is this just natural history? And you could argue that 5 to 12%, which is what's being presented out there on the mavacamten, is that a high number or is it a low number? Is it lower on mavacamten? And then you started with, if somebody has atrial fib, would I be concerned about using mavacamten? Everything Anjali said, I would agree with. I'll just add on, and I know she does this, is for me, that's a reason why it's done in a center where I might offer them and say, maybe this is an opportunity for us to talk about surgical myectomy plus a maze. So all the more reason to say, yep, Camzyos can be used, but maybe this is the patient where we say, if you've had frequent episodes of atrial fibrillation and you have outflow tract obstruction, we could do the full shebang in one operation. And by the way, maze is the best way to control this. That's a great option. And then there's always this need in cardiology to be an or. You're going to use my drug or your surgery. And I'm not sure we're there. I don't think we ever will be. I think it's going to be an and. I think there's going to be folks who have difficult myectomies deep into the ventricle that are incomplete, even with a plication. And it may end up being that folks need a little bit of both. And I think there's more data to be needed on that as well.
Well, that kind of leads into the next question we have here from Joe. What are we seeing long-term, if anything, regarding cardiac remodeling and reduction of thickness in those patients who've been on a myosin inhibitor for a longer period of time?
Sure. So I'm happy to start. We have data from the long-term extension study of Explore, so MAVA LTE, and that's perhaps the biggest group that we have longer-term data on. The phase 2 patients from Pioneer, also a little bit of data on them. And those patients are now getting out, several years, 4-ish plus years. And we have seen from the data both some regression of hypertrophy by left ventricular mass assessed by MRI. And we've seen that the left atrial size has come down. So both, I think, good signs that remodeling is occurring in a favorable direction. I don't think we have enough data yet on fibrosis or scar tissue. And again, I'll defer to Matt on his thoughts on that as an imager. But at least we've seen some signs within the heart structure and function that are favorable. It's still relatively short-term data. When you look at the life of a patient, someone who's starting on a medication like this in their 40s or 50s, what is it going to look like in couple of decades? I mean, that's what we really want to know. And then as we go further in earlier in the stage of disease, what would it look like if you're starting a 20 or 25-year-old? And I think those are all unanswered questions that we're keen to know, because that tells us when should we be thinking about starting these medications in the natural history of disease.
Yeah, 100%. The only other thing I'll add in is that we're seeing also T-wave inversions and normalization of ECG findings, which is impressive to me about disease modification. But then why isn't it happening for all of them? Because the gradients are all going away. And I think it's what Anjali just said, that we still need to understand, should we be starting this sooner? Should we really be focusing on the gradient if they have no true symptoms, that we can't elicit those symptoms, but their gradient's 120, are there still benefits to that group? And we just don't know the answer to that. I've certainly seen benefits in changes with diastology to some level. I think there'll be some things that are just fixed, that they've just done this too long. I don't know that we'll ever see reduction of fibrosis. I don't know that it'll ever be a risk stratification changing drug. I think that's important, again, to recognize this is about symptoms and not about risk for sudden death, at least at this point. But I do wonder that if, again, to go back to Anjali's point, if we start this sooner, do we prevent fibrosis, right? Do we lower the risk of developing or progression of fibrosis? All very much pie in the sky, but provocative.
Very provocative. I'll add a couple more provocative statements. Obstruction isn't good. If it's happening when you're young, it's less good because you have to live longer with the bad thing, right? So you don't have to be a doctor, you don't have to be a nurse, you don't have to be a patient advocate. Obstruction isn't supposed to be there. So the pressure built up, maybe it's not that damaging, but it ain't good. So if you can get rid of it sooner, one would just assume that would probably have a better long-term effect. So I will bring up another interesting finding of somebody that I happen to know is in the non-obstructed arm in a trial, and something came up, and I'm like, maybe we should have thought about this, but I didn't, and now I do. So because he's had regression of hypertrophy and his mass has decreased, his percentage of scar seems to have increased because his mass
Sure.
decreased. Does this change risk factors? If he was 12% pre-drug and we get rid of some of that mass and now he's 14.5%, is that a change in risk factors? I don't have an answer. I don't know that anybody could have an answer because right now I know an N of 1 or 2 maybe, but these are things we don't know yet, and it's really intriguing.
Yeah, absolutely. And just a reminder that the science of measuring scar burden is more art form than science. I will say that it is
inexact at best.
At best.
At
We need
best.
to be better at that.
And the way I think about this is there a whole bunch of scar that pushes me off the fence? Because it's still a 2B indication, right? Scar alone is a 2B, and it's really important. It's an additive, right? I love the way they did it in the original guideline. It's an arbiter, right? It helps push you off the fence one way or the other. And I think it's crept into the sort of the mindset of, well, I have a whole bunch of scar. That's my risk factor. I'll take my defibrillator. And I think it's more nuanced than that, and certainly the percentages change. What he just said, I love this discussion, right? So you change the LV mass and overall the percentage is higher. I don't know the answer to that, and I think that's a complex shared decision-making discussion if there's ever been one.
Absolutely.
That it is. And I do see that there's going to be some value for younger people to be placed on myosin inhibitors early and post myectomy. You get rid of the obstruction, but the muscle's still maybe not happy.
Yeah.
Is there going to be a role in the post myectomy patient? I do know a number of people who are in trials right now who are post myectomy, and they seem to be quite happy at the moment. So let's just hope that happiness continues.
Both the post-SRT patient population and also those apicals that you referred to, the apical and mid-cavitary patients will be included in the non-obstructive trials. So I think that data will be great to see, but I'm glad to hear that those patients have a trial to participate in because they have not much of any other option if they're very symptomatic. So I think it'll be great to see that data in that population as well.
Agreed.
So we have a question. I don't necessarily know that you're going to have an answer to this one. What, if any, I'm adding the if any, additional 2 to 3 data points would be most helpful to collect in the REMS program? So let's look at it from 2 ways. REMS means required and, kind of regulatory responsible. But let's take the mandate out of the word REMS and just say, what 2 or 3 data points would you like to see out of the total myosin inhibitor population at this time that we're not getting or that you think we should get more of?
Well, I'll tell you one thing I was surprised that we didn't have, which is the reason for stopping. So I heard that if you stop, then you just put in the patient status form that you stopped, but it doesn't say why.
Yeah.
So I think that would be one very simple bit of useful information is to know, why did this patient stop? Was it an adverse effect? Was it that they didn't feel well or better? What was the reason? And I think that's one very simple bit of data that would be helpful. Matt, as far as I know, they don't have that data.
They don't. It's not required to inform why. And you said all the things that I asked, which were, well, why'd they stop it? Did they go on to surgery, or could they not afford it? Did they have sudden death?
What happened?
What happened? and they can't answer it because it's too crude of a reason. And then the other question is, if the ejection fraction stopped under 50%, what happened next? Did the patient say, no mas, I don't want any more? Or did you lower the dose, recheck in a month, and then reset and increase? I have one of those where I went from 10 to 15 because I was trying to drop the gradient. Her ejection fraction dropped too low. That was a mistake. I went back to 10. She's back on the drug. She's doing fabulous again. I don't know that that's captured in there. And because that's going to help us answer some additional questions, which is, how come it's so rigid, 5, 10, 15? Why aren't we making it easier to go 10, 11, or 10, 12 and a half? We know in the pediatric study, they have those lower doses. Well, can I get those? I'm 50. Why am I being eliminated?
Yeah.
You have to, and I think that's really important. Everything else we titrate, right? 37 and a half of diazide, right? There's no drug for that. And
I think a lot of folks are trying the 7.5 and the 12.5 just to get a sense of, can we split that difference and make finer tune adjustments that may be required in some patients who, for example, have no more resting in Valsalva gradient. But when they do their stress echo, they do still mount a gradient and have a little bit of residual symptoms. And that might be the patient where you just up titrate by 2.5.
Yeah. And the other part of this is what were the circumstances around that scenario? Were they infected? Were they not infected? Did something happen to elicit that response? Those are all details that we just couldn't pull out. And then, did it happen early? I want to really know, did it happen early, right? And I think we actually may have that data. And I'm trying to go back and ask them that. Because people ask me that, right?
Yeah.
My own experience is that once they're stable, all is good. But that may not be true. And I want to know it.
And, in the long-term extension data from Explore and MAVA LTE, we do know that there are still some late drops, and whether they occur in the setting of intercurrent illness or AFib or some other reason, or whether they happen somewhat sporadically. I think that's important information to know so that we can inform our patients better and say, you're still at risk at some point, and we do have to continue these surveillance echoes, but maybe not on the intense schedule. Maybe we can space them out, or again, it goes back to that determinant of what might make your EF drop, and understanding what those are so that we can risk stratify people.
I could let these guys talk all day on this. This is really interesting. Okay, so if there's any other questions, now would be a really good time to drop them in the box, because we're going to let these doctors go back and be doctors now. Well, not that they're not being doctors now, but the patients that are probably waiting there. So a couple of other items I just wanted to bring up. The pediatric trial is going to be populating very soon. While the topic of today's talk is really focused on the 2-year anniversary of mavacamten, there's going to be both a trial in mavacamten and aficamten in the 12 to 17-year-old population, which I think is super, super important. But knowing that we're going to be recruiting 80 children with gradients of over 30 between 12 and 17, whose parents are going to be okay with them joining a clinical trial, it's a big ask, and it's a small population. So here's my call out to the community. If you have a child who was affected and you've not done an intake and navigation call with the HCMA, let's get you set up on that. And then we can help you identify a coordinator in hopefully your area that might be able to be available for you to discuss your child's participation in a clinical trial, and make sure that you are as comfortable as possible and you understand the trial and the obligation as clearly as possible up front, so that we can hope to populate this trial quite quickly. I am excited to see how it works in this population, but we've got to be really, really careful for obvious reasons. These are young hearts. We don't have a lot of data on these hearts and myosin inhibitors because we've not been able to do a trial yet. So it's exciting times. We need to focus on that. Both of your institutions will be recruiting for pediatric trials, correct?
Yes,
Correct.
CHOP will be.
So CHOP and Morristown will both be available if you're on the East Coast. I've talked to some other people around the country who are also going to be available. I get the question quite frequently about genetic therapy. I know there's one open trial right now. There'll be another one later in the year. Anjali, you guys are a participating site for one.
We will be for both, yes.
You will be for both. And Matt, not on the genetics yet.
No, we sent, so one of the patients in the current trial that's going to be dosed soon is from us. So what we've decided is that we're not ready for the infusion part of this. And we need smarter people like Dr. Owens to be in charge of this. I'm not ready for that. So I've referred them out, which I think it's just a reminder that we're all in this together, right? So we're not competing. And I would say the same thing to the companies, right? Let's figure out a way so that we can best figure out how each of these drugs is going to help our patients. So not yours or mine, it's ours. And that I can already come up with some scenarios where I might use one drug over another based on a bunch of stuff, how many medicines they're on, what kind of ejection fraction they have, dosing strategies, all those things matter. And I think this is another reminder of that.
Okay, I'm going to go Lisa off script. This is when everybody worries.
Uh-oh.
Yes, we do.
Okay, so for whatever the reasons, we have become a my team versus your team society. So is it a political party? Is it a sports team? Is it a TV station, a streaming network, or a drug company? And that is the wrong way to think about this. There are going to be people who are better on drug A than drug B because of their metabolism and just their biology. We want everybody to succeed in this space. We want more options for patients. I am agnostic. Whether you have a Medtronic, a Boston Scientific, or a St. Jude defibrillator, get the defibrillator. If you're going to take a myosin inhibitor, make it the one that works best for you and your family. If you're thinking about genetic therapy, look at the options, look at the differences, choose the one that is right for you. There will be multiple choices here. And I already see it happening. It happened with myectomy versus alcohol ablation. I'm team myectomy. I'm team alcohol. Like, guys, your septal reduction therapy. Yay, you.
Yeah.
So let's remember it's going to take a lot. Oh, we have another question popping in here.
And
So
bottom line, options are good. That's what we want, is more options so that we can tailor them to the patient in front of us. And that's the bottom line.
Yeah. And I want experience with all of them. Rich, right? Anjali and I have talked about this. When we decided not to do the current controlling genetic testing, I called her and I said, look, I don't know why I could do this. And I need somebody like you to be thinking through this. We're going to start sending them out because I want to offer it to patients, but I'm not the right person to be having this conversation. We don't have a transplant program. So I need to know why I wouldn't send them to the transplant folks, right? Because maybe they're transplant candidates and I don't want to screw this up because it's still all about the human in front of me, not about me.
Amen to that. And I think if we all just remember that, we won't have any trouble.
I like a big boat. Let's go on a cruise. Let's do lots of fun things together with big teams of people. This is what we've built. And it's really impressive. Okay, Lisa's going to get a little emotional on this one. And I've given this spiel before, but AHA, ACC, 10 years ago, 15 years ago, there was nothing on the exhibit floor about HCM. There was nothing in programs, maybe an article in one of the newspapers they would put out. And we were at the sessions at the furthest reaches of the convention center, kind of like where we got lost, Anjali, on the other side of Atlanta. Yeah, I have a picture. It was weird, but we got stuck on the other side of the convention center last week. So it used to be this rare thing that people talked about. We are like that. We are the hot thing. Like HCM is everywhere. We're on the booths, on the floor, the little kiosk things, the hand sanitizer stations, like we're literally everywhere. And all of a sudden, everybody's looking not only at the drug, but at the really intense community that we purposefully built. And I will take a little bit of credit for nudging people along to be structured, to brand themselves as an HCM center, to have that multidisciplinary approach. And now everybody in the world is going, oh, we get it now. That one's hard. That one you need a lot of people from different mindsets working in collaboration. So we've built a cool thing. We have good clinical trials coming. And in the next couple of months, we've got multiple clinical trials across multiple sponsors that are going to be looking to recruit about 1,500 patients with HCM.
Wow.
Unbelievable.
Wow.
What did we do? What have we done here? This is amazing.
Yeah, and there's so much more to come, right? I mean, Anjali and I did a session at ACC where we talked about even the definition, right? Do we need to revisit this and talk about how to handle this in women and how to handle this in apicals? There's if you're a fellow and you're listening, there's a whole career left, man. There's a lot of action that still has to happen. And thankfully, Anjali and I will still be able to pay our bills for a while because there's
We're getting old. We're getting old and tired. So we need help.
Absolutely.
I think that is very well placed, because what is happening, let's put Lisa's HR hat back on for a minute. So we've brought people to this concept that is a center. We've taken these lovely physicians and nurses and administrators and said, here's 100 patients, here's 500 patients, here's 1,000 patients, here's 1,500 patients, here's 2,000, 3,000 patients. We need more doctors to take care of the patients. And I'm going to acknowledge something that's happening all over the country. Wait times are longer. Wait times are just longer everywhere because you guys are getting so much volume. So young ones, you in residency, in med school, come to HCM. We want you here. I'm raising one of our own.
Well, there's science and physiology and cool genetics and imaging and heart failure. I mean, there's just from a science and an art form. There's so much happening in this space. It's truly rewarding. And then, by the way, you make people feel better, right?
Yeah, and the families. We can't lose sight of that, which is, I think, one of the most rewarding things on a day-to-day basis, is seeing multiple family members, generation after generation, and really having that longitudinal connection. I mean, that makes you feel good at the end of the day, is that these families.
So I'll tell you, it's not a Camzyos story, but I'm going to tell it anyway. So I did a funny thing last weekend. So I left you guys at ACC, went to an ad board for a day. Then I went up to Chicago to meet some people and do some talking. So that was all good, not podcastable at this point. But then I went to Indiana. And I went to Indiana for a very unique purpose. I went to go to a wedding. I have never attended a wedding of a client before. But this particular client, love you, Kathy, but she drove me up a wall. I was going for transplant. She was going for myectomy. Her anxiety was through the roof. And I wasn't sure if she was going to make it to her myectomy, because I might have done something to stop that, because we were going nuts together. I was waiting for her heart. She was waiting for her myectomy, and she was really stressed. We got her through it. We got to surgery. Yay. Then other parts of life happened, and she ended a relationship. She worked on herself for a while and found a new relationship, and kind of crawled out of the hole in so many ways. And I wanted to be there to witness this moment with her family. I just wanted to watch her walk down the aisle and be happy. I'm typically people's rainy weather friend. Like when things are bad, it's call Lisa the HCMA. She'll figure out a way out of this. I wanted to enjoy some of the good things on why we do what we do. And so I flew to Indiana, and I went to a little town in rural Indiana, and I watched a wedding of somebody who's been through an awful lot of stuff to get there. The good moments are why we do all of this, and in the hopes that we can give people more good moments and help families stay whole as long as possible. That's why we do what we do. And to everybody behind the scenes, whether it was early day myocardia folks, still of all of you that have scattered to the wind and we built this together, to the BMS team, the current and the past, because they do go through people in pharma, to all the clinical trialists, to all of the sites, to the coordinators, to the data entry folks. This isn't just like somebody takes a drug and you go, how do you feel? It's complex science, statistics, analysis, conversations, refinements. It doesn't happen overnight. And to get from a concept in 2012 to our second year of labeled indication use. That's really fast to do in 2024. We did it in less than 20 years, from concept to label to real world. So bravo to everybody who took a part in this, and most importantly to the patients who stepped up early into those clinical trials on a concept. They had faith in what we were bringing to them. The entire community had faith because we had good scientists like you two fine folks helping us guide this. So thank you to everybody who participated in any way, and even to those of you who tried to be in a trial and were turned down because you weren't the right person at that time. The gate will open wider as we understand the use of this medication more, and this class of medication will serve others far beyond the HCM community at some point in the future. Those are my closing thoughts. What about you guys?
Yeah, I echo that statement. And one of our patients who participated in the first in human MAVA trial, the phase 1, was the first patient we wrote a script for that many years later, from 2016 to 2022. And he was the first one, a very special patient of ours. And it really came full circle. And I think in my mind, that solidified that journey that you just said.
My niece, who does take Camzyos, was in the phase 1, the last cohort. It was not fun. No. It was not. I was witness to it all. She got a horrible migraine. We found the tolerance level that we cannot go past.
Uh-oh.
And when years go by and she's like, I'm obstructed now. Oh no, I must take that drug that gave me the headache. I'm like, they will not give you that dose again. So she was in the phase 1, and now she is a prescribed user from somebody else here, but I won't, disclose who might be prescribing her meds right now. Matt, what are your thoughts?
I think this has been a terrific session. I think that if you're a patient and you think you have HCM, then seek out some opportunities, because there's a lot of options now that we've never had before. And then to all of us, there are still so many that are undiagnosed. In addition to finding ways to manage MAVA with other patches and local opportunities, we also need to dive into other ways to find people. And as we get better at treatments, the discovery of those with HCM is important. Steve Amman wrote an editorial that I quote all the time, the search for obstruction. I think now we've continued to search for obstruction, but we also need to search for HCM. There's a lot of opportunity to treat people. And I couldn't be more excited to be part of the growth.
I think what you said earlier, and I'll jump back to it, was, are we going to redefine what the diagnostic criteria is? I'll go out on a very thick limb here and say, yeah, I think we need to. But I have already seen some changes. All the work we're doing with the American Society of Echo and helping community echocardiographers understand HCM a little bit better, I think they're getting the message. I had this event occur maybe like 6-8 weeks ago, where my Tuesday phone time was all middle-aged women from Wisconsin and Michigan who had thin walls, like 13s, but big gradients with really wonky mitral valves. And you start tearing apart the family history, and there's HCM elsewhere, deep in the family tree. But they had been ignored for long periods of time because 13 wasn't 15. And they're small women.
Yeah.
Why would we assume that a 5'4" woman who weighs 160 pounds is supposed to have the same size heart as a man who is 6'2" and 240?
Yeah. And now they don't qualify for mavacamten if they have a 14 or 13 millimeter and they have an obstruction of 130 millimeters of mercury. Boy, that's science that is just not good.
Yeah, we need to do better there. And I'm excited that we're having those conversations.
Yeah, agreed.
So we needed to have those conversations. So it has been a wonderful chat with you both today. Congratulations to all on the second anniversary of our labeled indication for myosin inhibitor Camzyos mavacamten. 2 announcements. If you're in the Denville, New Jersey area, tomorrow the HCMA will be live on opening day of Little League to do some training on Drill Dr. Heart. So if you want to come out to Denville, New Jersey and Gardner Field, we're going to be talking about Drill Dr. Heart. And then next Saturday, we will be training all of the volunteer coaches on how to prepare their teams. And once we kind of dust off the roadshow of Drill Dr. Heart, we will have a kit that you can bring it out to your own community and train everybody on how it's not CPR and AED. You already need that training, but this is how to build a little muscle memory in a response. What do you do? Who do you call? Where is the AED? Stop, think, plan, and when it happens, you call the drill and you can respond quickly and potentially save a life. I don't know if many of the listeners are from the New Jersey area. A number of years back, we had a baseball hit a young man in the chest. He went down. They did resuscitate him on time, but years earlier, we lost one to commotio cordis in the same exact way. So we learn, we get better, we evolve. If you want to learn how to do this, get in touch with us. And for those of you who are out a little bit further west, HCMA will be live in 3 weeks in Cincinnati with Christ Hospital, doing an on the road Big Hearted Warrior tour. So we're heading to Cincinnati. I don't know if I'll have time to go see Fiona at the zoo again, but I can always hope. We like Fiona. She's adorable. So thank you for joining us today. We appreciate your time very much. And to all of those who have provided comment, thank you. To all of those who've been helped by Camzyos, we're happy for you and we wish you continued good health. Thank you all. And that is a wrap for this edition of Tales from the Heart, a podcast from the HCMA. Thank you.